So let's get this party started. We're going to start off with Miranda Delatorre, and she will start her presentation as soon as she's ready.
Thank you so much, Dr. Connor. Last week, I was racing home after a fast-paced, high-stress day at the office. My name is Miranda Delatorre, and I'm a mom, a full-time working mom with 4 kids. I also happen to be married to an emergency medicine physician who works a busy schedule, caring for some of the sickest people in our community. As we sprinted out the door that morning, he reminded me that I needed to pick up a prescription for our daughter at the pharmacy on my way home. The pharmacy closed at 5:30 p.m. and I was pushing it. It was 5:28 and I arrived only to hear that her medication was not ready and required a prior authorization from our insurance company before it could be dispensed. While successfully controlling healthcare costs and ensuring medical necessity, prior authorizations are the most common administrative barrier preventing patients from accessing their prescription medications. The process can delay care by up to 12 days and increase administrative burden for healthcare providers. A federally qualified health center in Ohio has experienced the burden of this process. And evidence suggests that centralizing responsibilities and utilizing electronic prior authorization tools can simplify and expedite the process. A partnership with the director of pharmacy at the clinic led to a quality improvement project designed to bring a new workflow to reduce the prior authorization processing time to less than 36 hours. So patients like my daughter could get her medication quickly. The project was designed based on Deming's model for improvement principles that enhance patient care by standardizing processes. An interprofessional team collaborated to develop and implement the new standard workflow. The pilot intervention centralized prior authorization tasks with a dedicated coordinator using electronic tools to enhance communication between providers, pharmacies, and payers. 4 SMART goals were used to guide the process. They focused on workflow design, training, reduced PA turnaround time, and building a sustainability plan, which was a lot of change. And many of us know that changes fail, right? And successful ones don't happen by chance. Managing the tactical aspects of change, like what is changing and how much it will cost, is vital. But who is making the change and how they will feel about their place in it is even more critical. The Ohio Health Change Management Methodology is a goal-focused approach to change. It combines templates, tasks, and tactics for effectively managing the people side of change, and it was used to communicate effectively to staff and key stakeholders throughout the project. The PA workflow implementation occurred on Tuesday, June 6th. That day, all prior authorizations were routed to a centralized staff member who processed each transaction electronically using an online portal. 3 Plan, Do, Study, Act cycles were used to identify subsequent drivers of delays and to inform additional small changes during the project. The project team collected and analyzed data to determine how the new workflow decreased the time to PA determination. Data included standard timestamps that were extracted weekly from the EHR and EPA systems. Trends were evaluated 4 times throughout the project to monitor progress toward both the process and outcome measures. The project yielded substantial results in line with existing literature. In 12 weeks, 36 PAs were processed using the new workflow, which reduced the average processing time by 79%. Before implementation in May, the average turnaround time for a PA was 14 days. And in August, at project close, it was 3 days. While the average PA turnaround time did not dip below the industry standard of 36 hours, it did improve patient and staff sentiment as well as cost. In fact, a 78% reduction in cost to process was realized. Centralizing the PA workflow and using electronic tools yielded significant advantages for the FQHC. Both are strategies that have emerged as pivotal actions for improving operational efficiency within the healthcare ecosystem. This QI project demonstrated that consolidating PA-related activities and leveraging technology can save time and financial resources. While the results were meaningful, more work is needed to continuously improve the PA process. The industry benchmark is to complete 76% of PAs in under 36 hours. These efficiencies align with the broader industry trend of moving towards standardized processes to enhance quality, cost-effective care in alignment with the Institute of Medicine's 6 domains of healthcare quality. But what does this mean for you or for me? This means that at 5:28 p.m., after a very busy day, when I walk into the pharmacy to pick up my daughter's medication, the administrative paperwork will not keep me from picking up her medication and getting home to my family. It also means that for my husband and the providers at the Ohio clinic, that they can devote more time to delivering patient care instead of navigating complex manual authorization processes. In summary, healthcare leaders and professional organizations, as well as government entities, have extensively published the impact of PA on the healthcare system and patient outcomes. When a prior authorization is required, patients cannot pick up their medications from the pharmacy. The delay ranges from a few days to a few months. Current evidence suggests that pharmacy-led strategies with an interprofessional team can improve the process by implementing electronic tools and creating a standardized, centralized workflow. The Quality Improvement Project proved that taking a systematic approach guided by data can improve PA turnaround time and decrease cost in one Ohio-based clinic.
Thank you, Miranda. I apologize. I got so excited and playing DJ, I forgot to introduce our special guests. We have Dr. Decker, the president of Franklin University, Dr. Washington, and the whole executive team. So let me just pause for a second and turn it over to Dr. Decker and Dr. Washington. I'm so sorry. I can't do Colin's job. Please don't ever hire me to do that again.
Bonnie, can I speak?
You can.
Okay. Well, first of all, Dr. Connor, don't apologize, because what we're listening to here is actually the star of the show and not us. But I just want to tell you that the entire group here, which comprises the executive leadership of the university, is just thrilled to have the opportunity to listen to the first 4 of our outstanding DNP students come through and present their projects. And I sent around a description of the projects to the group earlier, and without exception, everyone is very impressed by the practicality and the actual contribution to improvement of care that's entailed in each one of these projects. So I congratulate each of you, and thanks for the opportunity to listen in. I'm going to let you go back to the rest of the presentations, and then maybe Dr. Washington and the rest at the end might have some comments. Thank you, Debbie.
Thank you, Dr. Decker. So any questions from the audience? Well, I'll start with one, Miranda. If you were to go back a year and a half ago, and look at what you've accomplished Do you believe that this project has the potential to make a change? Would you do it again? Would you do anything differently? Tell us a little bit, kind of off the cuff.
Yeah, I appreciate the question. I definitely think, from where I started a year ago, I knew that the evidence was strong enough to be able to make a change in the FQHC. I would say what I underestimated was how much I would have to fight for prioritization of the workflow change with the healthcare and clinic staff. They are an incredibly busy clinic. They are short staffed, like most healthcare organizations. And all of the things that were taking priority sometimes over my project, I agreed with them. They were making the right prioritization choices from a care delivery perspective, but I definitely underestimated that in initially planning for the project.
Thank you. Any other questions now? We'll come back to questions at the end. All right, hearing none, we're going to go ahead and move on to Kelly Manda.
Thank you, Dr. Connor. Let me share my screen. Hello, my name is Kelly Manda, and I am a nurse practitioner working in an orthopedic spine practice. Today, I am delighted to walk you all through our efforts to address the opioid crisis within our practice. We have implemented a distinctive quality improvement project to rectify our unstructured post-surgery opioid refill process, which has led to some overprescribing in the past. We conducted a comprehensive chart audit that yielded concerning results. It showed that half of our surgical patients were provided with multiple opioid refills, and 5% of them even required 2 or more post-surgery. This highlighted the necessity for a structured prescription protocol to enhance our patient safety and reduce the excessive refills. Spine surgery frequently mandates at-home opioid utilization for pain management. Yet our data analysis exposed an alarming pattern of excessive refills, surpassing the guidelines set forth by both California and the CDC. Our well-intended practice inadvertently added to the critical public health concern of the United States opioid epidemic. Our surgeon established the prescribing criteria when he began the practice, but we did not have a well-defined workflow. Patients received an initial opioid prescription on the day of surgery, with refills granted upon request. Medical assistants relayed these requests to the providers through notes on desk and occasionally resulted in refills being provided after their intended timelines. In 2021, the CDC reported that there was a 15% increase in deaths caused by opioid overdoses, totaling over 107,000. And according to the National Center for Drug Abuse Statistics, over 96,000 overdose deaths occur in the United States annually, with opioids involved in more than 70% of those cases. Our project's primary aim focused on reducing post-surgery opioid refills within the practice. This was achieved through the implementation of a prescribing protocol that emphasized patient comprehension, provided opioid education, offered a tapering strategy, and presented alternative options for post-surgery pain management. There is solid evidence backing the use of prescribing protocols, especially after surgery, to cut down on opioid use and refills. Our protocol was inspired by the University of Michigan's Pain Management Patient Agreement and was designed in alignment with various national guidelines. The implementation of our protocol, firmly grounded in strong evidence and in accordance with national guidelines, has yielded a remarkable reduction in post-surgery opioid refills. This achievement not only enhances patient safety, but also optimizes pain management, showcasing the positive impact within our practice. We followed the Institute for Healthcare Improvement's Plan, Do, Study, Act model, continually analyzing data at every stage to drive our improvement initiatives. Our change process was expertly guided by Ohio Health's comprehensive change management tools, which encompass team assessments and patient surveys to gauge protocol compliance. During our initial PDSA cycle, we introduced the protocol following a 3-week training period for our staff. Surgical patients received the protocol and were informed about the specific expectations regarding opioid use before their procedures. They acknowledged their understanding and commitment during the preoperative visits by signing the acknowledgement form. In our initial PDSA cycle, we discovered a gap in care for our non-English speaking patients. For the second cycle, we adapted the project by providing translated versions of the protocol into English, Spanish, and Armenian to better accommodate the diverse demographics of our patient population. After completing the second cycle, it became evident that the preoperative explanations did not effectively clarify patient expectations. In the third cycle, we introduced a joint protocol review between the providers and the patients on the morning of surgery to improve their comprehension and resolve any lingering questions. In our final cycle, we acknowledged the ongoing need for improved patient education. Our change strategy included giving patients a discharge handout that outlined alternative pain management methods. This initiative empowered patients to explore different options before considering the use of opioids to manage their pain. To evaluate the protocol's effectiveness, we conducted a comprehensive data analysis, including 1 process and 2 outcome measures. Our dedicated medical assistants recorded data during patient visits using a custom spreadsheet. This approach enabled us to assess both the adherence to the protocol and its influence on 2 key aspects of our patient outcomes. Our aim was to see a 75% reduction in opioid refills over the span of 8 weeks. 74 out of our 76 patients followed through the protocol and weaning plan, resulted in an outstanding compliance rate of 97%. This far exceeded our initial expectations and provided solid confirmation of the project's success within our practice. When it came to the project's process measure, our goal was to have both providers achieve a 100% signing rate for our protocol within the 8 weeks. Only 2 patients out of the total participants did not receive or sign the protocol before their surgery. This led to a compliance rate of 97%, demonstrating the success of our efforts in this aspect of the project. Our final outcome measure, we had strived for all of our surgical patients that needed continued opioid therapy at the 8-week post-surgery mark to be referred back to their primary care providers and/or pain management. Only 2 patients fell into this category, and both were smoothly referred to pain management after their 8 weeks, achieving a flawless 100% compliance rate for this outcome measure. The data from the project makes a compelling case for permanently integrating a prescribing protocol into our daily practice. With our 97% compliance rate and a substantial reduction in opioid refills, this evidence-based approach to postoperative pain management promises significant benefits for all of our future patients. Our project, which focused on postoperative spine surgery patients, successfully reduced the need for opioid refills. It exemplifies our proactive, evidence-based approach to addressing a critical national issue, going beyond mere statistical success. It highlighted the impact of thorough data analysis and a collaborative effort in post-surgical care. Thank you all for your time and consideration on this very vital issue. Our determination to minimize opioid refills and enhance patient well-being continues to be our guiding force. This project's success serves as a testament to our unwavering commitment to patient safety and our responsibility to our community. Are there any questions at this time?
Thank you, Kelly. That was wonderful. Some questions?
This is Dr. Melanie Brewer. We can't get her video to come on at the moment. Kelly, tell me just a little bit about what surprised you about your results, if anything.
Thank you, Dr. Brewer. What surprised me most was that throughout the project, as we were going along, and the preoperative education became a very vital part of the project success, and patients walking into surgery with the expectation to know that they're not going to be continually giving refills past a certain point, and that we were offering them alternative modalities to help with their pain, really helped to drive those numbers down. We started seeing far less refills right out of the gate, because I think knowing they had an expectation going in helped them to realize that they weren't going to just keep getting refills forever. So they started looking at other ways to manage their pain really early on. And I had an astonishing amount of patients that were completely off of the opioid refills 2 and 3 weeks post-surgery.
That's phenomenal. That's great work and really, really great presentation, Kelly. Thank you.
Thank you, Dr. Brewer.
Well, we have a shy audience, but maybe they're
I have-
waiting until the end. I heard somebody.
Yeah, I have a question. It's Dr. Van Ravenstein. Kelly, do you know if the two people that weren't off the pain meds, just out of curiosity, were the same two people that didn't sign the protocol?
No, they were not. They were
Interesting.
chronic long-term pain users from previous, and they were just continuing on their medication therapy.
Okay, thanks.
Now I'm on. Okay. Hi, Kelly. It's Wendell Seaborn. Quick question. Remind me again what you said your success rate was of all the patients that you were dealing with in this protocol.
For compliance of being weaned off at the 8-week mark was 97%. And
I thought you said a very high number. I just personally want to thank you for the study that you've done, the project that you put together. I think many people in this room already know this, what I'm about to share with you, but my son had surgery 11 years ago, and he was given opioids for 2 years of refills. By that, he was completely addicted, and 2 years later, he got a batch of fentanyl, and it took his life. And so I personally thank you for your work in this area and preventing these unnecessary deaths. To me, it's a great comfort to know that others are looking at this.
thank you very much. I'm so sorry for your loss.
Well, thank you.
Kelly, it's Dr. Van Ravenstein again. I just wanted to tell you too that if you're not thinking about publishing this in a journal, you really need to. I think this is highly publishable, and it's something that is very generalizable to other practices and could really, the information that you give out would really help other practices control this. Because I mean, I remember working in orthopedic practice, and the amount of pain medication that was doled out to patients post-op was just astounding. So just really, I think you should publish this in a journal.
Thank you very much. I'm going to look to that.
And I believe, Kelly, that your physician provider and your office manager are here today. And so I want
they
to
are.
personally thank them for allowing Franklin University to come into the practice and do this project. I'm a little choked up, Dr. Seaborn, and I just want to thank you for sharing. So I think at this point, we'll move on to the next presentation, and then we can come back to questions. Fabulous job, Kelly. I'm really proud of you. So next, I'd like to introduce Leslie Meredith, and she's going to take us on a different journey.
Thank you, Carrie. We can start. Right. So imagine yourself or your spouse being 31 weeks pregnant. Your baby is being whisked away into the neonatal intensive care unit, and all the unknowns of what could happen are running through your mind. The last thing you're probably considering is providing your child with human milk as you're focusing on the next minute or 24 hours. Hello, my name is Leslie Meredith, and I want to discuss a quality improvement project conducted in the NICU to increase human milk at discharge rates. At the bedside, our nurses will ask parents about their desire to breastfeed, and lactation consults are placed. However, delays occurred up to 24 hours to 48 hours in this department. As a result, the unit acknowledged the need for a unit-based lactation support team. According to the CDC, only 3 out of 4 mothers in the US start out breastfeeding or providing human milk. Therefore, it's important that mothers are encouraged to provide human milk due to its nutritional benefits for their infants, such as aiding in their growth and development. Providing lactation support is instrumental in initiating and establishing breast milk supply and maintaining production through admission and post-patient discharge. As the organization strives for best patient outcomes, The goal to increase human milk consumed within 24 hours of discharge was set to 80% from a baseline of 47.4% for this department. Evidence shows an increase in breastfeeding rates were due to lactation support, specifically a trained certified lactation consultant or counselor. This quality improvement project implemented a unit-based lactation team. The team was comprised of 7 trained healthcare providers. They provided education about the benefits of human milk. They offered breast pump instruction, and they addressed any concerns or problems from admission to discharge. The team also utilized a quality improvement framework to refine processes for better patient outcomes. It executed 3 tests of change when results weren't ideal within an 8-week time frame. Who doesn't want more support during this critical time? In the first week of the project, we did observe an increase in hospital-based lactation team services due to a new initiative that they had. This caused some duplication of services and overwhelmed some mothers. As a result, our unit-based team looked and reviewed at the unit and hospital-based lactation notes meetings to avoid patient redundancy. Secondly, our charge nurses conducted audits to ensure breast pumps were available for all mothers. Initially, audits were inconsistent and pumps were not always available. To address this, visual reminders and pre-printed audit forms were introduced. When non-compliance was noted, charge nurses ensured that pumps were placed at the bedside. Third, there was a focus on achieving 100% compliance with daily and weekly lactation support meetings. Challenges did arise, and some mothers were unreachable and team members were unavailable. Assigning a backup team member for each shift was put in place to address this issue. Throughout the project, we utilized the Ohio Health Change Model to guide implementation. We emphasize effective communication. Roles and expectations were defined. However, changes, when they occurred, meetings were held or emails were disseminated. Regular updates and project results were communicated through team and stakeholder meetings. The department aimed to attain 80%, which was benchmarked against national and international standards set by the Vermont Oxford Network. 3 process measures were established to track progress: the breast pump audits, the daily meeting compliance, and overall mothers providing milk. So how did these interventions impact our outcomes? We saw an average increase of 42% over a 2-month time frame for human milk at discharge, yet not hitting the 80% goal. Additionally, breast pump audits achieved 92.5% compliance rates. Daily and weekly meeting compliance fell short of the 100% goal, but reached a compliance rate of 78.9%. Overall, 61.3% of our mothers during this period provided human milk, which was close to our 75% goal. Lactation support was pivotal in impacting human milk provision in the NICU. The support system empowered mothers to make informed decisions about their infant's care, resulting in increased breastfeeding and human milk consumption rates. Wouldn't you want this type of dedicated support for you or your loved one to ensure your baby had the best nutrition possible? Breastfeeding and providing mothers with support during their NICU stay are essential to family-centered care and the improvement of breastfeeding and human milk at discharge rates. Thanks to the dedication of our nurses and lactation team, we anticipate continual positive results as the team remains committed to delivering exceptional care to patients and their families in the year ahead. Thank you for your time. And does anyone have any questions?
Thank you, Leslie.
Thank you.
I have one quick question for you. So you spoke about using the Ohio Health Change Model, and you did a fabulous job, by the way. Congratulations. And yet there was a department
Mm.
that didn't know what was going on. What would you, I mean, it was probably out of your control, but now looking back, what would you recommend a student who came behind you with a similar project do to try to get all the stakeholders if they could be identified?
Yeah, and I know within different organizations, there's various meetings that individuals are invited to from various departments. So definitely making sure getting on everybody's calendar. Of course, within the departments that you're mainly holding, the projects and things with your leaders and things like that. Yes, you're giving that information and you're there with that team. But then there's overall very high level meetings as well that, as leaders, we can attend and things like that. So yeah, reaching out and seeing what all meetings you can get on basically to get to all of them so we can have that communication down to from the high level down to the unit level.
Great. One more question. So the state of Ohio, this is kind of a mandate, right? That they want the human milk before discharge. How are you going to get the results of your project over to them so they can highlight it for others?
Think making sure that I definitely get in contact with other key stakeholders that can get that information there, of course, and making sure that as an organization we're getting that information up and out of our doors is going to be, very important. Of course, publishing too. That would help. So getting on that, making sure that I do that in the near future as well.
Other questions? Great, we'll come back to that. Great job, Leslie.
Yeah, thanks.
Last but certainly not least is Lorelei Solita, and she's going to take us on a completely different direction.
Thank you, Dr. Connor. Hi, I'm Lorelei Soleta. As a wound specialist, I have been providing consult to more than 50 patients a week with pressure injury, and I witness how it affects their quality of life. The title of my project is Enhancing Pressure Injury Prevention Bundle in a Skilled Nursing Facility. Pressure injury is a localized damage to the skin and underlying tissues over bony prominences due to constant pressure. It can be caused by immobility, poor tissue perfusion, and incontinence. However, pressure injury is considered as preventable. This injury can negatively impact patients, family, and healthcare system. Up to 60,000 deaths per year can be attributed to pressure injury. One of them is Superman. He died from the complication of pressure injury. Pressure injuries can affect anyone regardless of who they are. In 2022, there's an increasing rate of pressure injury despite using a prevention bundle. We discovered that repositioning of patients was not performed regularly. Repositioning or turning patients is important since it prevents constant pressure on the bony prominences. Air mattresses was also issued for patients with a Braden score of 12 and below, which is not effective. According to the analysis conducted in 2022, most of the patients that had pressure injury had a Braden score of 14. Braden scale is an evidence-based tool that healthcare facilities use to assess and document a patient's risk for developing pressure injury. If a patient's score is 12 and below, it is considered as high risk. If it's 14 and below, it is considered as moderate risk. To prevent development of new pressure injuries while in the facility, a quality improvement project was implemented. The primary aim of this project was to add evidence-based interventions to the existing pressure injury prevention bundle. Review of the evidence had shown that consistent turning and repositioning patients and using air mattresses is effective on preventing pressure injury. It also emphasized the changing of the Braden scale cutoff score to 14 or below. The use of system reminder is also effective in preventing pressure injury. It can enhance staff compliance. In summary, system reminder, consistent repositioning practices, and providing air mattresses are effective in preventing pressure injury. The duration of the project is 12 weeks. Key stakeholders include the Chief Operating Officer, the Director of Nursing, nurse managers, and the clinical educator. The Director of Nursing was responsible for overseeing the implementation of the project. The changes that we implemented includes mandating air mattresses order for patients with a score of 14 and below, along with adding turn and reposition frequently. Education was provided to the nursing staff on the new intervention. We also add the task of turning and repositioning patients frequently to the nursing staff task list in the electronic medical record. Data collection was performed with the Director of Nursing and clinical educator using the electronic medical record as a primary data source. The process measures our issuance of air mattresses and completing and documentation of the turn and reposition task. The compliance goal is 80%. The outcome measure is a 20% decrease in the pressure injury incidence rate. The Plan, Do, Study, Act cycle was utilized to facilitate the testing of changes. 4 cycles were conducted during implementation to mitigate any barriers. The Ohio Health Change Management assisted with communication and addressing potential barriers. After implementation, the compliance rate for issuance of the air mattress to all moderate and high-risk patients is 100%. This accomplishment was achieved without any challenges. The inclusion of reminder in the electronic medical record proved to be effective. For the turn and reposition frequently added in the task, the first week is below the 80% target. The education was provided to the nursing staff, resulting in an increase in compliance by the second week. The compliance rate was maintained until the end of the project. For the completed documentation of turn and reposition frequently, initial implementation show a compliance rate of only 52%. Re-education efforts for nursing staff resulted in an increase in compliance. All the process measures are above the target goal of 80%. The baseline incidence rate is 6.2%. During the intervention period, it was noted that only 6 patients had acquired pressure injury. This led to a 1.74% drop in the incidence rate. The change percentage is more than the target goal of 20%. Using evidence-based offloading intervention resulted to a 72% reduction in pressure injury incidence rate, which is more than 3 times the goal. The use of air mattresses and frequent turn and repositioning for moderate and high-risk patients is effective. This project not only saved life, but also improved quality of life. Absent of the injury, let our patients enjoy the activities that they love to do. Thank you for listening to my report. I'm so fortunate to be given a chance to improve the life of our patients. Thank you.
Oh, Lorelei, thank you so much. And as a former rehab nurse, I can certainly appreciate pressure injuries. So, you know, long-term care is a difficult venue. What's going to happen when Lorelei is not there anymore? Do you think, what is the sustainability plan?
I know, I'm so fortunate that the Chief Operating Officer of the facility is also a nurse. So he's into this, he's really supporting this. In fact, he bought a lot of air mattresses again after the success of this implementation.
Excellent, and that will save him a lot of money in the long run.
Yep.
Excellent. All right, so any questions for Lorelei? Then we're gonna go back. There are some questions in the chat. And we'll start back, but let's give Lorelei a chance. Do we have anything for her? Well, I'll give you a chance to think about them. So Miranda, there's a question in the chat. Was there any resistance from office leadership related to needing a dedicated staff member for the prior authorization process?
So I was fortunate in the FQHC that I worked with. They actually had a full-time medication access coordinator who was focused on managing their 340B program. She had some bandwidth to be able to take on centralizing all of the prior authorization work. So no, there was not any pushback. However, when I did my stakeholder presentation out to the organization, because this was a pilot, when I encouraged them to think about expansion, I did also make the recommendation that they would likely need to hire at least one additional full-time individual to support additional providers.
Thank you. Great answer. I have another one in the chat. Where to go? Kelly, this one's for you. Were patients with chronic pain medication use identified prior to surgery?
We knew that they were. We didn't have any specific documentation that showed that they were coming in with prior chronic use. It's in our medical records. I just didn't identify it for tracking for the protocol for the project.
Thank you. I want to read a note to you from George Armstrong, who some of you have met. He says, on behalf of Ohio Health and the Ohio Health Change Management Team, I want to thank each of you for utilizing our methodology, and we are so happy to have contributed in a small way to your individual project results. George, I'll have to say it was more than a small way. Our students embraced the tools that you gave them. I have another question from one of our adjunct faculty for all of you. How did you incorporate health information technology into your projects? Did you identify any challenges or strengths in collaborating with IT staff? And was the collaboration necessary? Great question, Dr. Temes. Go ahead, Lorelei, because you had the most IT.
So for my project, one of the weaknesses of the facility is the lack of compliance. So I did approach the IT person of the facility if they can change a little bit the electronic medical record to include a system reminder. So with including the system reminder in the electronic medical record, we were able to help the nurses to remind themselves that the patient needs an air mattress or turn position. With working with the IT, it's kind of challenging because it seems like they always don't have a time because they have more priority. But eventually, she realized that she really needs to help me. So yeah, I really work hand to hand with the IT person.
Thank you. Dr. Van Winkle, I saw your hand up.
I did have it up for a moment there, but then others were asking great questions and I wanted to make sure that they were discussed and such. But my question was for Miranda. If I remember correctly, in your presentation, you said that there was a significant cost savings as well as improvements in the time frame for the prior authorizations. What type of cost savings were noted, especially since in future questions, it sounds like the talk about additional personnel might be needed and that.
Yeah, so the cost savings, it was a 78% reduction in cost. So the way that the clinic was processing prior authorizations prior to the project was the nursing staff were actually all doing it in a decentralized manner. So it was kind of a side job for multiple nurses. By centralizing and standardizing the process, we were able to reduce the processing time, and it was only leveraging that one centralized FTE. So we were able to reduce the cost, time spent by their average hourly wage pretty significantly. And that was to support one clinic, and there are actually 10 clinics in this entire FQHC. So that one FTE in the future, if they choose to do it, would be to support those additional clinics.
Fantastic. It sounds like it was a win-win overall.
Yeah. I think they were all win-wins. Do we have any other questions? And if not, I'll turn it over to Dr. Washington, and then I have some closing remarks. Any other questions? Fabulous
Looks like
job.
Lisa has her hand up.
Okay, it didn't show up on my screen. Go ahead, please.
Hi, thank you. Yeah, I couldn't find a little hand wavy thing. My question is for Lorelei. You did say that you did have some patients who still did develop pressure injuries. Were their labs evaluated to see if there was contributing factors, low albumins, things along those lines, where that patients, regardless of our protocols, sometimes develop injuries through actually no fault of anyone. It's their body breaking down. Did you identify these patients in labs?
Yeah, so we did look at the albumin. So we actually, that's one of the process in the facility. If they have any patients with acquired pressure injury, they do a root cause analysis just to see where it's coming from. So we determined that these patients have low albumin, low zinc because of poor appetite. And also they've been spending more time in bed because they really decline their health. So that's one of the problems.
Thank you very much. Appreciate it.
Any other questions? In case you can't see, before you guys click off, I want you to scroll through the chat because there's lots of compliments for all of you in there. Hold on, I just got 2 new messages.
Yeah.
Dr. Washington, do you want to say something?
Yeah, I don't know, can they hear me?
Yes.
I just put a message in the chat so that I could be brief. I'm so impressed by the quality of these presentations. Demonstration of theory to practice. If meaningful change was your goal, mission accomplished. I'm very confident in your ability to be effective leaders and practitioners in your field. And so thank you so much for the work you're doing to address student-centered, patient-centered care. Just impressive. I'm walking away feeling uplifted by these presentations.
Let's have a round of applause.
Thank you. So remember, folks, I told you I had a surprise at the end of this presentation. So in front of the university administration, your peers, other DNP students, faculty, folks from your organizations, other special guests, Dr. Delator, Dr. Manda, Dr. Meredith, Dr. Solita, you may now call me Debbie and call Dr. Brewer Melanie. Thank you so much. It's done. Congratulations. You did an amazing job. Thank you everybody for coming. And if our doctors can stay on the line for a minute and faculty and other students, we have a few minutes left. I'll let the rest of you go about your day. And thank you, Dr. Decker, for changing your agenda so that everybody can attend. And
Thank you for your great work, Debbie.
thank you.
Good job, everyone.
All righty. Well, that was beyond phenomenal. We had some tech issues, but that happens. I don't know if any of you could tell because I couldn't tell what you were reading, but you did a great job. You kept plowing through. What consummate professionals you are, have been, always will be. This is an opportunity for anyone who's on the line that wants to offer some congratulations, words of wisdom as you join us in the Academy of Being a Doctorally Prepared Professional. And I turn the floor over to whoever would like to speak.
This is Dr. Timmis. Great job, everybody. I just want to piggyback on what other speakers have said already. Please publish your projects. It really does contribute to the DNP practice. It contributes to the body of knowledge that we have to pull from. And you guys did an excellent job. So please take the time, do the work, and publish.
Thank you. All of the manuscripts will be posted on the Franklin University Scholarly Exchange. called Fuse. It will be a few weeks before it's there. And the link is on your program, if you will, the abstract book on the back cover. Then hopefully our graduates will rewrite those into publishable manuscripts for journals. As written, they're just project reports. But thank you, Dr. Temis. Anybody else? I see a lot of students coming and going. All right, doctors, do you have anything you want to say? Can you talk? It's over.
We just all are thankful today is here and done. And thank you, Dr. Connor and Dr. Brewer, for all of y'all's help and guidance through this process. It's been a long journey for everybody, and we're all just happy to be at the end.
Now you can breathe.
Yeah, I'm gonna cry so hard later. I'm gonna say that.
All right, my husband went and bought a bottle of champagne, so all righty. Well, if there's no other comments, then I will let you go about celebrating. You all did an amazing job. I am so very proud of you. This has truly been an absolute honor. And we will send you a link to the videos. It'll take a while for Zoom to process it. And yeah, have a great day.
Thanks. Bye.
Thank you guys.
All the best. Congratulations again.
Bye.